items are in the didactic piece beforehand, I'd love participation. So with that, let me go ahead and share my screen. Okay, so as you mentioned, we're talking about serving children with disabilities and their families. I do have to admit that when I was developing this, I did include a broader definition of children. I included adolescents and young adults in that as well, because our age groups get wider and wider when we're talking about disability and service provision. So I hope that's okay with everyone. So no disclosures, no conflicts to report here. By the end of this morning, by the end of the COP, for those who aren't as familiar, or for those who work in it every day, you know, want us to be able to define and discuss with others the prevalence of disability, both nationally and what we see in West Virginia. Talk about the historical approaches to disability and how we provide services across the lifespan, and how that might have changed or stayed the same over time. Talk about common service needs and what gaps still exist and have been noted through research and studies. And then finally, talk about how our rural living here in West Virginia and in Appalachia, and particularly discuss a little bit of a discussion about social determinants, which we've had across several of our COPs in this series, how they may influence how we provide and who we provide those services to for disability services. Okay, so as many of you already know, when we talk about and we get started, we want to use a definition. Well, the definition of disability is varied. And so you pay attention to how it's being defined based on where you're looking, where you're finding it. So here are just a few of the different definitions. The first one is something from, it's the community survey. So a lot of the surveys and a lot of the data we have even define it differently. So one in particular, the American Community Survey, just really focus on non-institutionalized individuals. Others speak to different areas of impairment, and I've highlighted those for a reason. Impairment in some area, some condition that limits an activity or restricts participation in something, and that's from CDC, that second one. So it's really focused on, later we'll talk about strength-based approaches. For this definition, it's more of an impairment-focused piece. The third one is simply from the dictionary, Merriam-Webster, and you'll see impairments being a consistent focus, something that creates a disruption or limits someone to reaching a goal in some shape or form. And then the last one is from our Social Security, which is very specific and relates to a time frame of not less than 12 months. It speaks to whether it's continuous or very specific in time, and it's medically determined. So in all of those, there's not one that's, as mentioned, is not universally accepted, but you need to find your definition and look for data, statistics that use that same definition. That can be a challenge. So like I said, our services are becoming strength-based, while our definitions and some of even the eligibility criteria within the area of disability are really focused on limitations. Okay, let me move this real quick so I can see. So in terms of types of disabilities, and many times when you serve, you say at least one disability. Some people might have more than one, and more than one different type. But here are generally the buckets used to describe the types of disabilities. So you have visual, hearing, some cognitive disability, ambulatory, self-care, and or independent living. And these are the areas or realms where someone might have that limitation or disruption in that area. And this is across age groups. Okay, this isn't just for children, this is across age groups. So disability can be varied in and of itself. So you can have over here disability related to conditions that were present at birth, such as Down syndrome. You can have developmental disabilities that are apparent later in life, maybe later in childhood, such as autism spectrum or ADHD, when they start getting into the classroom. A disability related to an injury, such as a TBI or traumatic brain injury. Something related to another condition, such as diabetes. And I know in some presentations, we've also talked about connections with patients who have had a cancer diagnosis. And then a disability that might be progressive over time, such as muscular dystrophy. So the impact can be varied based on a lot of factors, even within a disability. So that was all to get at prevalence, right? It just depends on what you're looking at. But the general description, this is the most recent statistics, and you can see straight West Virginia, we are a dark blue. We have a high proportion of disability of all types. But this one's from ACS, so we know their definition is non-institutionalized individuals. What this is showing is male or female, so both genders, all ages, all races, all ethnicities, and education. So this is across the board by state. So West Virginia has one of the highest, and it fluctuates. We switch back and forth with a couple of states on who's the highest, but we have a high percentage rate of disability in West Virginia compared to other states. If we use the CDC definition and their types, here's the prevalence. This is not just for West Virginia, this is also nationally. We notice that most of them, and one person can be in more than one bar here, okay? But mobility disability is the most common. And then a cognitive disability, then independent living, so something that's a limitation with independent living, hearing, vision, and then self-care in terms of the distribution or proportion of disability. Now we know that particularly young children, and since that was our original focus of this, is children with special health care needs, particularly young children may not have had a diagnosis, or it might have been, one of those like ADHD or autism spectrum that really by the end of the 0 to 5 years you're starting to see, but some of them may not have. So really you see a term called children with special health care needs being used. And that is another general description that can include all the different types of disabilities that we saw in the first few slides. So that's why we're switching this term. That's how it's collected. And it can be physical, it could be cognitive, it could be all of those types. But within 0 to 5 years, the national prevalence is about 7.8% of children of that age have a special health care need. And that jumps up, doubles to 14.6 in the middle childhood years, 6 to 11. And then adolescents, you have 15.8% of that population having a special health care need of some sort. Just to continue this out, what does it look like by race and ethnicity? It's pretty equally distributed, one by income, which is interesting. We don't see that often, but special health care needs is, you can see the range, 12.8 being the lowest income over there on the right, to 13.6 being the most affluent families. And then there is a greater prevalence. If you look at the bar chart on the left, there's a greater prevalence reported among Native American or Alaska Native children at 16.6, followed by children who report a mixed race, and then non-Hispanic white, and then you can see it progress from there. So non-Hispanic Black at 13% of that population with a special health care need. Native Hawaiian Pacific or Hispanic at 8.6. So we do see a significant difference based on race and ethnicity, but not so much of an income difference. And these if you're curious, I do have resources listed at the end. This comes from the Special Healthcare Needs Report that I'll list the full reference later on. So what are the implications for a special healthcare need or a disability? And as a developmental psychologist, I would say it depends. Psychologists like to say it depends for many situations, but of course, we experience and have different resources and different needs at different times in our lives, and so the impact's going to affect us differently. Having a special healthcare need, and this is based on the literature, might, not a guarantee, none of this is causal, but might impact attachment between a caregiver and a child. It would require a particular change or difference in environmental support that others are able to give that child. And so it pulls a lot of resources from those around that child, and whether they can meet those or not is definitely a test at a younger age. As they get older, it may impact interactions with other children. And again, depend on the type of disability, whether it's a mobility issue or intellectual disability. It may affect that social interaction in very different ways. As they continue to grow older, we see as early as kindergarten, and sometimes even pre-K, although the literature was just looking at it and results still out. But as early as kindergarten, that the goal setting of whether this child would graduate with a typical diploma was being questioned. So it does affect goal setting down the road, or it could. And then confusion early in childhood or delays in intervention could lead to early planning. So if you don't know something is up, or you're not prepared, or you don't have the resources you need for a child with special health care needs, you can't really start to plan effectively and fully. And so that could have long-term consequences. We need to keep that in mind for our later discussion. As they grow up, get a little older into the teenage years, adolescence is a time of strife and a little bit of chaos mixed in. So these kids are no different than that, finding their identity, finding who they are, their people, their place. So struggle for inclusion might be an issue. Increased or continued educational challenges would continue potentially. Social situations with peers might also continue, and they have far more reaching impact for an adolescent than perhaps a younger child. And then this last bullet, prognosis and risk behaviors, there's a pretty growing big literature on this, in the sense that depending on the condition of the child or the adolescent, you see a peak, you see a high or an elevation in risk behaviors. And some of the research that, reasons why they might see that is, for adolescents who might have poor prognosis related to their condition, think, I have nothing to lose. And as part of maybe the inclusion of peers or just wanting to live life to its fullest, you see them engaging in a wide variety of risk factors. It could be drug use of various levels. It could be risky sexual practices, but there is a higher and elevated level of risk in some subgroups of adolescents with disabilities or special health care needs. Okay, so here's where I took a little bit of a liberty and kept us going in the lifespan. So the impact of a disability on an adult. And this is really just in a vacuum as an adult, not counting all the experiences that they might have brought with them through childhood and adolescence, like we just talked about. But as an adult, independence is key. It should have come from adolescence as a start. Now you're a young adult and you're continuing through. And from a perspective, we're all, and someone with a disability also thinks of this way, we're independent, we want to strive for independence. So if we are able to broaden our horizons, if we're able to reach those goals, if we're able to reach that independence, depends on a little bit of us, a little bit of our environment, a little bit about opportunities available to us. And as service providers, we're part of that piece, whether we provide access to that opportunity or make it really hard. So again, we're going to keep hold of this for our later conversation. As an adult, family members' awareness of their inner strength. So if they're providing caregiving, maybe the adult is not the person with a disability, but providing caregiving to someone who has a disability. It's inner strength, family cohesion, connections to community groups. This requires a lot of that individual. And they need resources and respite and the ability to get support. So there's that tug of war between, in that sense, for that population, caregiving, and then what they want to do as an adolescent or as an adult, excuse me, and how to share that up and make that equal to the person they're caregiving. And then finally, worry and confusion with changing roles. If this is something particularly that hasn't been a chronic or hasn't been a lifelong disability, might have just happened related to a condition or over time with age, it is a swift change in roles from maybe a child to a caregiver for a parent. And that can be a difficult transition. And then lastly, for families, families are the immediate support, arguably, and the same things apply. Their inner strength, their cohesion, it's a test many times. Many families in the literature I reviewed were talking about just this pull, and then they felt guilty about it. But there was no doubt they were committed to providing services for their family member or friend in many instances. But it is that give and take. Additionally, time and financial costs associated with this are regularly listed for families and parents providing caregiving. Physical and emotional demands. Maybe they're not able to work because they need to stay home and take care of a dependent with needs. And so what happens? How do they keep everything going? And then marital conflict is another one that families might mention. Okay, so families are a key piece. The individual with a disability is a key piece to pushing this forward and meeting their goals. Like I said, we are a key piece to that as well. And there have been different approaches historically and even currently described. And so I wanted to spend a little bit of time. I'm sure you all have seen at least one person do each of these approaches, but maybe you didn't know the name of it or how, that it had been studied and things of that sort. So we'll just take a few moments to look at these. So charity model, medical model, social model, human rights, and then the biopsychosocial model are the ones that are listed and compared. Keep having to change my view of this so I can see. So I took the first four approaches because in the literature, they have been compared to one another, and I wanted to talk about that. And so you can imagine just by the name of them that they vary greatly based on what they focus on and the amount of inclusion or the amount of support of independence that they might include. And so this is just a visual over time, kind of that conventional form of thinking. The charity approach has been there, again, may not have been referenced as such, but has been there for the longest period of time. Then you see a medical model approach come in, and then the social and human rights approach is coming in around the 70s. Okay, so a little bit about each. So charity approach is really looking at someone and really having sympathy for them, right? Oh, I feel so bad. What can I do to help? That it's somehow maybe a negative by nature, but it's a pity in a charity. They need assistance. Okay. So persons with disabilities are in a tragic situation if someone's using this approach. This is kind of their worldview. Person with disabilities cannot take care of himself or herself. They inspire compassion and are objects of benevolence. We need to be kind to them. They need assistance. So in terms of how that goes into action, so they need our help, they need our sympathy and charity. We're going to collect and give money to provide the services to them. They need any service. So that's that last bullet of quality of care may not be regularly on the radar because anything is needed in a charity approach. And who's responsible for this? Anyone who's kind enough to give it. Foundations, individuals, churches, you name it. Okay. Medical model, a little different, more scientific focus, but it really came from that rehab counseling perspective. Still had that sympathy for people, still had that element of charity, but we can fix it, right? So maybe it's more focused on that condition, and we can assist with that condition and make it a little less problematic. All right, so persons with disabilities can be or need to be cured. This is something that we can address. Persons with disabilities have a passive role in this because it's really the condition that we're focused on. Persons with disabilities are considered abnormal. Now this, I'd have to say, is an older version of medical model. Medical model is coming along pretty quickly on moving this to include the individual with disability and things. This is, though, based on the historical medical model. And then persons with disabilities are unable to live independently. And you see that in our systems, right? Our larger systems really are built for certain types of disabilities. And now we're talking about assessing independence, assessing, you know, opportunities for allowing them to have, independent lives and things of that sort. So it has definitely moved, but in general, this is how the literature describes this. The approach, of course, rehabilitation piece, right? You're focused on the condition. You really want to reverse this experience. And then who's responsible? Providers who are able to work on that condition for us. Sue, I see I can't see the chats. Will you let me know? You interrupt me, or everyone interrupt me? I think it might be people just saying who's here. Okay.
Yeah, nothing yet.
Okay, thank you. All right, so combined, you know, this is again prior to the 70s, you have a few things that also went along with these two models, which were the most popular. So you had kind of this disempowerment piece, particularly from the charity. You know, they're not part of the process. We're gonna decide things for them. So disenfranchised stigma definitely was in full force. Institutionalization came to being and was definitely very popular. That related to segregation, dependency, and then low self-esteem among individuals with disabilities. Okay, so then around the late 60s and early 70s, we start to see the Disability Act, and we start to see some policy changes as well as practice changes. And this is where you also see the medical model starting to modify in its approach. And that social approach was the first one that came to being. And we had a lot of sociological things going on around that time. So we need to eliminate the barriers to enable the participation of persons with disabilities. So this was now a focus shift on the environment, on what we might be doing. They have a greater capacity. Let's let them have it. So hospital, schools, transportation, all of these pictures represent various opportunities for equal opportunity for individuals with disabilities. So we were organizing our communities, our society in the wrong way, in a way that led to all those things: dependency, kind of fading into the background. Then that someone with a disability really focuses on that environment. At least the first big step is to change that structure, and then let them work on, and we're going to talk about other factors that came into play, but then that would allow them to have options at first, and then that people with disabilities should and can participate in any opportunity, given the chance and the support. So big focus there: eliminate environmental barriers, really focus on public services. The accessibility piece really came into play, and who's responsible? All of us. So, but particularly the legislators and the ones that were developing the structure of our society. Okay. So, and these were the different levels, right? There's so many levels, many ways of walking, and this is just to diversify our definitions a little bit more. Different ways of walking, seeing, thinking, communicating, interacting, and you name whatever else, and we need to be a little bit more broad in our inclusion. And then next came human rights approach, which you saw our state advocate groups then being developed, and our DD councils starting to focus, or at least they were established to do that. So persons with and without disabilities are part of the same society, and we have the same rights and obligations. This is the self-advocacy piece and the advocacy piece to it. So sociological was the environment, changing our society structure. This one now is what the individual with disabilities can do. Self-advocate, and what we can do across the board. So full and equal enjoyment of all rights for persons with disabilities. Equal opportunities, non-discrimination at work, at school, again, all different domains. Requires authorities to ensure rights and not restrict them. So then we start to see more laws and equal opportunity pieces, legislative pieces, that would put a little bit of teeth into the game. And then views persons with disabilities as rights holders. So empowers them. If they're not getting that experience, those opportunities, here's what you can do. So an enforcement of laws, new policies being put into place, equal recognition, and who's responsible, still legislators, but then this would also include all of us, right, for the advocacy piece. So you almost have the flip opposite of the charity approach. You have inclusion in the decision-making, in the participation, accessibility to anything. And even today, right, 40, 50 years later from the ADA, we know that people find loopholes, and that buildings need to be ADA compliant, but if you check them out, the grade is like this, and it's very difficult to get into a certain office building. We're much better than we were back then, and we continue to grow, but there's still some accessibility issues. But that's the focus, something that's non-discriminatory, something that respects diversity and opportunities, okay, and gives them the dignity that they had all along. So we've really come a long way in our approaches, and even though, again, you could probably identify at least one person in your time being a service provider who has taken each of those approaches at one point, or has that perspective of it. And you can see it, again, to focus back on children with special health care needs and how a disability might impact them. They're in the classroom. How do other kids view them? How do we talk to our children about disabilities, and what approach do they take? So it's an evolving concept. It involves communication, interacting, learning from one another, seeing it happen, and knowing that we need to change it. It has environmental pieces, it has individual pieces. All of us have a particular responsibility in the outcome. even down to language. And I have to include this. So the language has changed considerably. So we might have victim of, and now we say person with, and then you fill in the blank. That, I'm going to use traumatic brain injury, just recently has changed from someone or a survivor of a TBI. Just last year at the national group level, these persons with a TBI. And trying to get that empowerment piece and the less victimization and limitation sounding. So suffering from, afflicted by, persons with, okay? And the idea is if I have a cold, yeah, I might say I'm afflicted by a cold or suffering from a cold, but I have a cold. You know, it's something I have, it's not me. It's not me as a human being. It doesn't define me. And that's the empowerment difference. Invalid, no. Okay, the R word, no. Mentally handicapped, intellectual impairment. And all of these pieces, we don't go through a class per se with this. We have people first language now that we can get a lot of this. We may not know that the way we say something might automatically from the get-go be setting a tone. So this is just an example of how we've moved forward. Now, we're here talking about services, right? And so this illustration just shows different types, and each of you on this call represent a different type of service. And you might go outside of your bubble, your particular type of service, and you might connect someone with a disability or a family member to another provider or help them navigate through. Because this looks all nice and pretty and the bubbles align really nicely, but it's actually like this for families. They hear this, oh, I got to go here. Well, I just talked to them. Oh, and then I go here and here and here and here. So many of you connect and put it into focus, but all of these are needs, could be, that a family or an individual might need. So what are those needs? Okay, so let's go back to the data. All right, this is from less reported to the most reported. So substance abuse treatment at this time of survey was the least. Now this was prior to 2019. And I would say this is probably flip-flopped in certain regions. This isn't by region, this isn't, you know, this is nationally. And I'd say in West Virginia, I'm biased, but I would argue that that's gone up. Anyway, that was lowest at the time. Communication aids, then mobility aids, home health care, hearing, medical equipment starts to go up with the most need, the greatest need being prescription medicine. And in the literature, it's interesting because when you're talking about prescription medicine, when the issue with opioids started, raised its ugly head, individuals with disabilities were immediately impacted. Now, for some, depending on their condition, an opioid might be the primary medication. And a lot of the literature had scenarios, had situations where that was just taken off to us before it was assessed, or taken out because people were really worried about all of this, and then they came back. Again, the disability section may or may not have been the immediate factor for the opioid regulation, right? But they were impacted. So there were several. Then NIH and other institutions wanted to take a look at it. What is the impact of this opioid epidemic on individuals with disabilities? Do they have greater use than another population? Were they impacted in some other ways? So that was within the last 2 years, and those studies are still going on to take a look at it. So that was a big need. Dental care is another, and then preventative care is another. And that's a whole separate presentation I could do where you name a condition, obesity, sedentary activity, diabetes, and individuals with disabilities are at greater risk for those conditions. So preventative care is key. But then you run into many studies, and I'm just going to talk about this as an example. For obesity, sometimes it gets difficult, particularly in some clinics, to measure someone's weight if they're a chair user, right? They don't have the scale. That's not, you know, so studies ran into that. Different case studies noted that. And so sometimes it's self-report weight, which can lead to a whole different type. So those factors, you know, it gets complicated within each one, but those three are the most commonly declared. Now that changes by age. Okay, so the blue bar is that 0 to 5 group, the young ones, tiny ones. Orange, 6 to 11, and then yellow would be our adolescents. So the adolescents, the longest bar is mental health care for adolescents with disabilities. Same thing for our middle childhood group, 27.6. For 0 to 5, the longest bar for them is medical equipment, maybe some specialty equipment at 21.2. But you can see in general, very different patterns of what they need based on age. Okay, and then this is across a couple of different resources. So in one survey, 18% of families needed at least one healthcare service that they didn't have in the past. Now this was a special healthcare needs survey that was done. They were asked about just their common care services that they get or they don't get. Okay, now in this report, they did note a big difference based on finance. So in the sense of the needs differed for poor children. 32% need at least one service. Uninsured children needed at least one service, 46% of them. Dental care continued to pop up. So it was the second largest on the last study or national survey. It's also the most commonly in this national survey. Others, again, mental health services, specialty care, and therapy such as PT, OT, and speech come into play in certain parts, certain age groups. For families, they also talked about what families need, like a 2-generational approach. And so the families were saying they needed family counseling. Again, we know from the impact that families must redefine what they knew is now very different. They struggle with that balance. They struggle with the guilt and the need to provide services. So working through all that is needed. Respite care is huge. It's one of the biggest ones. And then genetic counseling. Many families want to understand why. And they want to understand, so what does this mean? What are we locked into this? What's the prognosis? How do we change this for other kids or individuals in the future? So one of the highest for caregivers is caregiving education and training. We all know that there's not a manual for being a parent, and there's definitely not one available for caregiving someone with a disability. There might be people along the way who have pamphlets, who have very helpful documentation at one point or another, but the bigger picture and connecting the dots and bringing it all together, or that training might be very quick. They're asking for more education and training. Walk me through, give me examples. You might have to tell me a couple of times. I'm going to tell you what I'm experiencing at home. How should I respond? Those kinds of things are what's described. Again, respite care, I can't say that enough. That is all over the literature. That's all over. They need a break, a little break. They need those legislative, those structural society structures that give them that little break. Finances are limited often. Having flexibility in the workplace so that they continue to work and get that paycheck and support their families is key. Direct pay for being a caregiver was also something. And these are focus groups for more than 95 individuals who, in very different roles, were providing their thoughts on what they needed. And then changes in tax policy to benefit caregivers. And here's just some of the quotes. There were many quotes, but so caregiving training is a service that's needed that you don't know that you need until you're there, right? I don't really have full confidence with the resources that are offered. There's not really much alternative to pick from. For me, it's truly just the break from everything. This is for respite. Resources that could come in to take some of the burden off. And then lastly, the tax credit. I looked at my last 15 years of Social Security benefits. It's sad because I got zero for several years. What am I going to do when I'm 62? So those are the types of services that they're asking for. In many ways, there's a lot of effort to get them, those services. There are remaining gaps, though, that we're not quite hitting, and here's some of them. So we still know that individuals, like with some of those conditions I mentioned, individuals with at least one disability, and you pick the type, any type, had a repeat emergency department visit. They also have a greater likelihood of getting back into the hospital for care. They have a greater likelihood of intensifying the level of care needed. That's part of that preventive piece. Greater likelihood of needing long-term care, and then premature mortality. And each of these, of course, it's not a straight disability to this. There are many factors that go into this. The premature mortality, I know one example is, end-of-life decisions have included, in the past, have included individuals who have certain conditions which would not need end-of-life, but historically they've been put on that list. You have that part, and then you have the part of, because of all the lack of support and preventive care in all the different levels, they just increase their morbidity. Another remaining gap is opportunity to work for individuals with disabilities. And so here are just a few stats in an infographic. For every dollar paid to workers without disability, those with disabilities receive only 63 cents on average. So there's a pay gap. You can look at it by, it exists by education level as well. So in that second part, the light green is without a disability, the dark is with a disability. So a pretty big pay gap going in and as it continues. And then let alone, this is when someone gets an employment opportunity, it's hard to find those opportunities. Okay, we know that medical access still, even though we're doing a lot and increasing, doing our best, we know that the majority does not have a personal doctor or nurse, or at least reports as such by national surveys. So why is that? That might be a personal preference. We know that some people do not go back after an experience they would perceive as bad for a variety of reasons. Maybe they can't get there. Again, a whole bunch of different factors, but we still know that having a consistent physician, health provider, nurse, anything is something that many report they don't have. And this is for the different groups. So again, by lifespan, what are we looking at? So parents caring for young children with disabilities, again, you talk about tax incentives. They're staying home with those children, and many times having to quit their jobs. So having some means of support. Caregiving training, we've talked about, and then the respite. For family caregivers who are taking care of an adult with a disability, their focus is mainly on long-term services, the tax credit, and then also the caregiver care or education. We do have that third group, which are adolescents caring for adults. And that's a whole different group, right? So they're at a time where they're developing, and as we talked about, it's very important for them to be able to do certain things. And so what is the impact on them? Are they able to complete school when they're having to work and keep everything going at home? And that's part of that financial worries that they normally shouldn't be thinking about, having to think about. And then in West Virginia particularly, but Appalachia as well, grandparents and kinship caregivers. So financial considerations are huge. Respite care is important. They need a break too. And then future planning. I'm a grandparent, or I'm of older age. What's going to happen if this child's a baby and still not of age and something happens to me? Or I'd also put into this group an adult, a parent who's caregiving now an adult with a disability, and they're thinking the same thing. What's going to happen if I pass on, and what's going to happen to my child who's now an adult? So just to kind of finish this out, and this is in general our services and things that we need to consider, it's not just us, the responsibility is not just on us as service providers. We are in that environmental factors. We are one piece. And those environmental factors are things that are at our disposal too, or may not be at our disposal. We're talking about rural settings, and not every specialty care may or may not be. They may have to drive long distances. So we can make the connection, but you know, we're one piece to that environmental factor. The personal factors is the individual with a disability and their interest. And if you empower them, do they want to continue, and what do they want to do? What are their goals, and do they align with what you have in mind and what the larger group has in mind? Those interact, and then you can have a whole variety of social participation. You could put a lot in it, and the person still just is not ready to interact. And you continue to work on it, right? Or the person can be pushing the rest of the group saying, this is what I want to do, and you're coming along with me, right? They can be a very strong self-advocate, and that's great. So here's where we talk about social determinants and all of this, and how much should we be aware as service providers? I think being aware of people who might be vulnerable to not having services, being aware of if our institution that our facility that we work for, or even our own behaviors might differ a little bit based on some of these factors, being conscious of that. Identifying or recognizing when it does happen and trying to provide services to those who don't. Those are pieces that we pull from this. So physical, of course, we do still see some gender differences, some racial differences that we've already talked about, even some differences based on type of disability, okay? I think in the literature, people describe an intellectual disability as perhaps, in terms of a person's independence, getting that last versus someone who has a mobility disability. So someone who's a chair user might be incorporated into a work site or get more opportunities now than someone with an intellectual disability. Because that communication breakdown, it could be familiarity, who knows, but there's differences based on type of disability. Psychosocial impairment, they could be very functional, but the interaction with others could cause some barriers. And then just like anything else, does it fit the individual or not? Do the circumstances fit the person or not? That's the individual or the physical. Socioeconomic, of course, poverty, connectedness, access, social isolation, education, reading level, all of those definitely apply anywhere, but particularly in the rural setting. And here are just a few others. So, and I hope this comes out in the case study, right? So if you've served Clay County, you might have a different response in terms of accessibility and resources and how you would approach someone, a family, than Morgantown. Maybe not, right? But all of these pieces kind of go into that a little bit. Okay. All right, so what is your approach to disability? You don't have to say it, but think about what your approach has been. What's your facilities or institutions approach in general of those 4 or 5 approaches that we talked about? Do you consider the individual or the individual within his or her family and larger context? Because that's another thing I'd want to leave you with is you cannot really think of just the individual with disabilities in a vacuum by himself or herself. You have to include those other pieces, and how you include those other pieces is up to you. But that multiple generation, regardless of how old the individual is kind of important. Respite care is universal. How are we going to do this as a society if everyone is saying they need it? Tailored services are key. It's not redoing a service completely for each individual, because that's not possible and that's really expensive. But modifying it based on these factors when needed and feeling confident that you could do that would be great. Asking for resources. If I have someone who comes in who lives here, who has this background, this experience, how should I tailor this? Particularly in rural settings, but anywhere, service coordination is essential. We can't just do our part and leave it be. Not for individuals with disabilities and their families. There's so much for them to connect that navigation is essential, that coordination. It ranges from nothing available to 15 things available, and which one do I go with, right? And then caregiving training based on the literature. That's another one. What would that training look like? If someone provides that, who's on the COP, please let the group know. Let us know when we talk about our case study, because that's interesting. I mean, I couldn't find examples. What's in a curriculum, or what's in a training for a caregiver? How long is it? When do you give it? That I couldn't find. Okay, so any questions before we get to our case study? And how are we doing with time? Good.
I have one quick question.
Okay, Jackie.
This is Jackie. I noticed on your map of the U.S. when you were showing West Virginia in the dark blue that all of the 3 states in Appalachia were the 3 that were in dark blue. And I just wondered, does anybody have any idea of why that is? I mean, I know that there's places that are inaccessible and they're rural, and perhaps there's low poverty, but it just bothered me that you can just see it right there, plain as day. Arkansas, Kentucky, and West Virginia.
Mm-hmm. So it was interesting. We were talking about this in emails today with our impact program officer, and she asked a question of, well, is it related to the type of workforce, the type of jobs we have? Coal mining, and we have these hard jobs, and particularly for certain types of disabilities, I would say that is a factor, right? And we do, one of our highest in West Virginia is the mobility and independent living. So one of our highest disabilities are those that come in later in life and could as a result. Others on the call, there are other factors that have been proposed, but what others think? Why are we darker than Pennsylvania or Ohio or even Virginia?
Yeah, Lesley, I think you're right that it's a lot to do with workforce and industries that have gone. I think there's also a lot of research and data on generational poverty and dependence on reliance on benefits in a generational way. But yeah, there's a lot out there specific to the Appalachian region and a focus on poverty, which usually leads to a focus on disability and other areas of being disadvantaged.
Other explanations that I've heard is that West Virginia tends to have more of an aging population, so less people go to college, grow up, move away, or if they do join the military, they come back, or people who have grown up in West Virginia and move away tend to come back to West Virginia for retirement. So more of an aging population, I think, if you look at across the United States, the average age, which then comes with acquired disabilities, arthritis, hearing impairments, chronic health conditions, and things like that, that would factor in.
And access to healthcare in general. Some people in rural populations just don't have the facilities available to them or the kinds of care that they might need to have access to be able to be treated. And then there are cultural norms. And Lesley was talking about the preventative care that's so important, that a lot of time people in Appalachia, I don't know if it's West Virginia specifically, but they don't necessarily go to the doctor until they're sick. And by that point, they may have something that can't easily be helped.
Yeah. Good point. Definitely good point. Okay, and I realized I was, all my slides took up our hour, so I mean, I just want to show you this, and I'm going to leave you, instead of doing our typical discussion, which I think is important, I do want, you all to think about if you had a scenario where you had a 3-year-old diagnosed with NAS, recently diagnosed on the spectrum with autism spectrum. You have a single parent, so we're weaving in some of those environmental factors. She gets support from her mom, so maternal grandmother's helping out. The little girl, makes vocalizations, is able to say one word, one recognizable word, but the rest of them you can't really recognize. Cries and falls to the floor, has some behavioral responses to certain things, even the littlest things. And the parents coming to you, again, 3 years is pretty young, coming to you for assistance, right? Based on where you are now, you may not serve children who are diagnosed with autism spectrum. You may not serve, families with this age group, but think about what we've talked about here. And then I'm just gonna kind of, I guess, drop the mic, and then I want you to think about it, because just developing this made me think about a lot of things personally. So do you determine the family needs when someone approaches you? Like Michelle, Michelle as a single parent with a grandmother, and what would what things would you consider? What would you want to ask? What would their goals be? When you develop an intervention plan, which one would you start with? Right? And how would you figure that out? Would you incorporate Michelle in that process? We talked about advocacy, get empowerment. That would be great. How would you incorporate the parent training? And let me just stop. Does anyone have a caregiver training that they use on this call? Okay, so that's a gap. I'd love, I mean, that's the greatest need, and I cannot find. So how would we train Michelle? What would we train Helen, the grandparent, before we do the intervention? And then how do we progress it? Are we just focusing on Emily, the little girl? Are we also focusing on mom and how these social determinants might be changing? Okay. So these are big picture. I do have my resources. These are going out to people, right? So they would have the links. Yeah. Okay. So you'll have these links for both the data and some of the reports that I used in this. But what do you guys think real quickly about having that case study, or you know, pick one of these groups, a caregiver or an older individual with a disability? How do you weave in these pieces? How do you train parents? How do you incorporate them into your thinking? How do you select goals? Okay, so I'm going to stop sharing. I'll see some new. Okay, so Regis, SFC has training packets. That would be great. Okay. Parent Network Specialist provides advocacy training and parenting training. Okay, so maybe we need to get these out to the literature, right? Sounds like we're doing some of this. I could not find examples, just that they were needed. That would be great. CED has a lot of resources online. Okay. Anything else? We've hit the 4 o'clock, and I'm sorry to cut it off, but any other comments about disabilities, how they change over time, and what our stance? Yeah, respite care. I mean, it's just so pervasive. It's so needed. Respite care. People are burning out, right? And then they can't, they burn out, but they're still have to take care of a family member. So. All right, well, so just, we'll all think about it and continue to try to improve our goals and think about our stances and advocate for when we see a different approach that maybe isn't up to date. Let's see, Elizabeth, I think at this age, the ability for the child to communicate with their caregivers is key. Yep. So it's so key for that peer, right? She's going to be going into, we don't know about daycare. We don't know about pre-K, sign language. Yeah, those are great ideas, Elizabeth. Any other comments?
I agree with Elizabeth, and I would add that it's really important for the mom to be introduced to the different kinds of systems of services and funding sources, waiver programs, things that they need to get enrolled in, children with special health care needs programs, so that they can begin to be networked into the services and supports that their child's going to need, as well as like parent network specialists and other family supports that can help them make plans for as Emily gets older and starts to get into school, things that they need to be thinking about, looking ahead, things like that.
I think that's a really good point. That last slide that you all will get includes not only legal and policy quick guides for individuals to know what are their rights, right, to start that advocacy journey. There's a little bit of that. There's government and local programs near you. It's a click, it's a link that people can go to, put their zip code, and get a whole array of services that are around them. Children with special health care needs, the system, what is it, how to navigate, at least on the website is in there as well. So these are just meant to be starting resources. If you're not familiar with it, in West Virginia or nationally to take a look at it, and so you can speak about it a little bit more and start that connection. But definitely the coordination care, because many families that we see here at CED are in that realm where it's either I can't find anything or I'm on the wait list for 15 different things. What do I do in the meantime? And then lo and behold, I'm going to get a call from all 15 saying, I can do this, right? What do I do? What do I do? So we just need to get more familiar. So Jackie mentioned not all families have computers, and in a recent COP with grandparents particularly, they said they are a group that don't generally use the computers. So they gave great, if you didn't check that out, go back and check that. They gave great ideas for alternatives. Yeah, it might be a website, but how to give the same information to a group. Let's not just rely on technology. You're absolutely right, Jackie. And they gave some good ideas about what they use to stay up to date with their grandchild's schooling or connect with the provider when they don't usually use, you know, MyChart or something like that. Yeah. The other thing is not all websites are accessible. That is something that I took for granted and realized that actually many of them aren't. So check it out, ask around. When you find a website that's not accessible, let them know, because that is part of the ADA piece. Melina, cross referrals are needed. PT, OT, speech therapists need to be connecting. Yeah, you have many families who are saying they might have a piece of my service, know a piece about what's going on, and only I know the whole picture. I think the Paths for Parents efforts are trying to really cinch that up in many ways. That's why you need to incorporate the family member, because they know all that's going on. Yeah. Anything else, Melina, on that comment that you were wanting to?
Just that a lot of times the medical providers are the ones that are seeing the families first, and as they should, they're focused on, you know, their particular area of specialty, but they may not think to say like, oh, well, after you do all of these at-home therapies or exercises, here's some other groups that you need to link up to if you want to go back to work, or, you know, you have, you need respite care, or you need a support group. So just helping with outside of their circle.
All right. All right. Well, thank you, everyone. Sue, I'll turn it over to you.
No, thank you, Lesley. That was great. And we will share the slides, as Lesley said. If you have follow-up questions, you can reach out to me or Melina or Lesley. We do have our next community of practice that will be on July 6th. The link to the evaluation was in the chat and will also be emailed to you. Thank you for joining us and staying a little over with us, and have a great afternoon and evening. Bye.